thank you to Basu and the rest of the organized committee at Day for inviting me. When Basu first reached out and he expressed interest in having me speak at, I think it was around 12:30. I thought it was a trick because I looked at my clock and I realized I'd be presenting at 3 a.m. So thank you for moving my program to a little bit later in the morning. I've never been much of a morning person, but it was very worth getting up a little early here on a Sunday to present to an international group of my colleagues. I was very excited about being able to do this. So as Dr. Jane mentioned, Think Like a Pancreas is a book. It's now, there we go. I don't know if you'll see this or not, but it's now in its third edition. Third edition just came out recently. I've had type 1 diabetes personally for about 35 years now, and it's become my passion to teach others, both patients and healthcare providers, how to effectively utilize insulin in diabetes management. So let's start out just with a general question about why bother? Why do we want to put so much effort into learning how to manage glucose levels effectively? We're all pretty well aware of the long-term health benefits that uncontrolled glucose levels can cause, but there are a plethora of short-term acute complications that uncontrolled diabetes can cause. It affects a person's performance in virtually everything they do in daily life: their energy level, physical performance, mental abilities, moods. I know that when I'm not in a very good mood, the first words out of my wife's mouth is check your blood sugar, because she knows something's a little bit off, and it's usually the case. But from a hypoglycemia standpoint, we also have to be concerned about safety of not only ourselves, but other people because of the risk of accidents. So management of glucose levels on a day-to-day basis is really essential, and not just the overall A1C, long-term metrics, but really the day-to-day numbers, hour to hour to minute control that we're able to achieve. So the whole basis for thinking like a pancreas is what I refer to as blood sugar balancing. And I often tell people to think of this as walking on a tightrope, where on one hand you have factors that are raising blood sugar, and the other hand you have factors that are lowering glucose levels. And our job is to try to stay on that tightrope without plunging to imminent demise. And there are a lot of variables that we have to consider. I listed the major ones here, but towards the end of our discussion, we'll look at some of the more picayune, smaller, more detailed factors that come into play. But various aspects of food, not just carbohydrate, but also fat and protein and even alcohol, affect glucose levels. The slew of counter-regulatory hormones that the body produces raise glucose levels as well. When our bodies were designed, we had a multitude of systems that can bring blood sugar levels up. We've only got one that brings it down, and that's insulin. And that's why it's so complicated to try to balance the dose of insulin against everything else. And then lowering glucose, we have insulin, we have a variety of other medications as well. But we also have physical activity, as Sherry talked about just a few minutes ago. Now, basal insulin, I consider the foundation of anyone's insulin program, whether you have type 1 or type 2. Ordinarily, a pancreas will secrete small pulses of insulin every few minutes. The question is why? Why do we need this constant flow of insulin in the bloodstream? And the answer is due to hepatic glucose output. The liver is secreting glucose in minute amounts throughout the day and night. The liver is under the influence of a lot of hormones, though. So the level of insulin secretion can vary based on the time of day. And this was some research I participated in several years ago, looking at basal insulin requirements by age. We didn't find differences by gender, but we did find differences in basal insulin patterns by age. And for the most part, young people who are still in their growth years tend to produce large amounts of glucose throughout the night. Adults tend to have more of a peak effect, we refer to as a dawn phenomenon, oftentimes. Uh, and we also find differences by age in terms of the magnitude of the dosage requirement. Young children require less than teenagers do because of all the pubertal hormones that are being produced and the insulin resistance that those create. But I was interested to see that older adults actually tend to require less basal insulin as well. Again, related to hormone production, which diminishes as we age and causes the liver to secrete less glucose. So even though older adults still have that peak effect in the early morning, the magnitude of the doses tend to be a bit less than they are in younger and middle-aged adults. So in terms of figuring out a basal insulin dose, how do we do this? The old notion of a 50-50 split between basal and bolus insulin doesn't usually work all that well. And this is something that really does need to be individualized. Go back one step. In this study, there were 322 patients included, and no two had the same basal program. This is a highly individualized phenomenon. The peak can occur at different times of day. The magnitude of the peak versus the valley can be different. It's a very individualized process. We can't just pigeonhole everybody into the same type of insulin program. But in general terms, for people who are active, who consume at least a modest amount of carbohydrate, the basal insulin dose usually gravitates towards 30 to 40% of a person's total daily dose, at least in type 1 diabetes it does. In people who are less active and eat less carbohydrate, then we start to see closer to a 50-50 split between the basal and the bolus insulin. As I mentioned, basal insulin doses do tend to decrease with age. And when we convert from injection therapy to pump therapy, we typically see a reduction in the overall basal insulin requirement. And it doesn't mean that a person's producing less endogenous glucose. It simply means that rapid-acting insulin delivered as basal tends to work a little bit more efficiently than what we see with the long-acting formulations. When adjusting the dose, and this goes for virtually any version of basal insulin you're using, including an insulin pump, with injected insulin, we set the dose to try to achieve steady glucose overnight. That's the critical aspect, is the overnight phase. So we typically recommend that somebody consume a healthy dinner, take their rapid-acting insulin with dinner, and then not eat after dinner, not exercise, not take any rapid insulin after dinner, so that we can evaluate the pattern that occurs overnight. From bedtime to morning, we expect a relatively steady glucose level. If the glucose rises or falls, we'll generally recommend an adjustment to the basal insulin dose. And keep in mind that the quality of the number is meaningless when we're evaluating basal insulin. All we're looking for is whether the glucose is stable or rises or falls. So somebody who goes to bed with a slightly elevated glucose and that glucose drops to normal by morning is actually getting too much basal insulin. That's a sign that the basal insulin dose needs to be reduced. Whatever they start the night at, that's where they should stay to determine if that dose is correct. And there are some variables that can come into play. Even when you determine the right dose of basal insulin, it may require adjustment for things like heavy physical activity the day prior. That's usually going to require a little reduction in the dose. Alcohol consumption can affect it. Again, we usually reduce the dose. And we're even finding that with high-fat meals, people tend to require extra basal insulin for quite a while afterwards. So we sometimes have people increase the dose. Illness also will require a dosage adjustment. So the ways we can deliver basal insulin, and again, this is just a schematic looking at what average basal requirements look like, where there's a bit more of an increase in the early morning hours. Most people need less basal insulin in the middle of the day. So how do we simulate that? How do we at least start out with an insulin program that has a chance for success? Well, we can use NPH insulin. It's still available. It's very affordable. We can use NPH insulin twice a day. We can use injectable insulins like Lantus, Levemir, Glargine, blue lysine, et cetera. Levemir. Or we can use an insulin pump where we can vary the amount of basal insulin delivery on the hour. NPH given at nighttime only does provide a definitive peak. However, that peak can be excessive, and sometimes people don't need that much extra insulin towards the early morning hours, and that can cause nighttime hypoglycemia. There's also an issue of running out of basal insulin late the next day, which can cause glucose levels to rise. And of course, with NPH insulin, we have this ongoing struggle of having inconsistent action. It's difficult to predict the actual PK of NPH insulin and PD because it varies based on the site of injection, activity level, and so on. So that's an ongoing issue. So what if we complicate things and give NPH twice a day? Well, now we're looking at a pattern that doesn't even remotely match what the body's basal insulin needs look like. Unfortunately, everyone with type 2 or type 1 who takes premixed insulin twice a day, this is what their basal insulin program looks like. And we have a multitude of problems from this. We still have the issue with the risk of lows during the night. We have the risk of lows during the daytime. People have to stick to a very regimented schedule with their meals with this kind of insulin. It doesn't cover lunch all that well because there's not a peak that's acute. It's more of a spread out peak all afternoon. And now we're dealing with not one, but two insulins a day where the PK/PD is very unpredictable. So what if we go to a long-acting basal injected insulin? Of course, that's got to work better, right? Well, not always. This doesn't tend to offset the dawn phenomenon all that well. We often see a rise in the glucose overnight. We also tend to see a drop during the day if somebody doesn't eat their midday meal or if the meal is delayed. And particularly with Levemir, one injection may not last a full 24 hours, so they'd have to take this twice. So what do? We can raise the dose in order to cover the nighttime need, which, you would keep the blood sugar from climbing overnight, but now during the daytime, you have way too much insulin in place. Glucose levels can decline significantly when somebody's not eating, and that can cause daytime hypoglycemia. If physical activity takes place during the day, as Sherry mentioned, the risk of hypoglycemia would be extremely high. So what do? We can lower the dose. We can give somebody a dose to provide coverage during the day so that they're stable. But now we have the problem of an insufficient dose at night where glucose is rising dramatically. And we have the issue of fasting high glucose, which is going to kill someone's A1C. So this isn't always ideal either. So with an insulin pump, we have the ability to fine tune the basal insulin and truly match it to an individual's needs. However, it's essential that patients be tested and fine-tuned, that you can't just start somebody on a pump and assume that their basal is going to look like this, because 9 times out of 10, it won't. It's going to need to vary and be customized to match their individual needs. Pumps also give us the unique ability to make temporary adjustments to the basal delivery. And that's very helpful for things like prolonged exercise, high-fat meals, illness, stress, etc. So it's a nice feature to be able to use. Let me skip over this. And let's turn our attention to bolus insulin requirements now. The job of bolus insulin is really two things. It's to cover the carbohydrate in food, the initial rise in glucose. It's also used to correct elevated blood sugar levels. In terms of the carbohydrate coverage, the dosing, and this is something there's a lot of misunderstanding about. Many people are told, well, see where your glucose is 2 hours post-meal. If it's high or low, then the meal dose is off. Well, I would say if it's low, it's off. If it's high, it may not be off, because we have to give these insulins time to work. And in most individuals, the PD of rapid-acting insulin is 3 to 4 hours. So we have to look at the glucose 3 to 4 hours post-meal to really see if the dose is correct. Determining an insulin to carb relationship or ratio it's a practice in math. It really does require some analysis of data. We need patients to keep records of their carb intake, so they have to be able to count carbohydrates reasonably well, and then we can evaluate if the insulin is covering that amount of carbohydrate. The ratios tend to vary from meal to meal, with breakfast tending to be the highest dose of the day. I'd say in at least 90% of the patients I work with, that's the case. Timing is also critical with bolus insulin. What we see are postprandial spikes in the glucose when insulin is given too late. And unfortunately, with so-called rapid-acting insulin, giving it right before eating is too late. With meals that digest fairly rapidly, the insulin needs to be given 15, 20 minutes in advance. And keep in mind that all carbohydrates, except for fiber, are going to turn to glucose. It doesn't matter if it comes in the form of complex or simple carbohydrate, it's going to become glucose eventually. So let's look now at some of the different approaches to quantifying the carbs. I was taught the exchange system back in 1985 when I was diagnosed. And it took me less than a week to take that whole pamphlet of information, crumple it up, and throw it in the trash because it just wasn't working so well. It's complicated, it's limiting, and it's not that accurate either. Looking at food labels is a much better approach for quantifying carbohydrate, as well as looking up carb amounts on apps and in handy books and things like that. Because granted, not all food comes in a package. Your fresh produce items, your baked goods, restaurant meals, etc. There's generally no labels on these kind of things. So being able to look foods up is very helpful. As well as being able to estimate portions. This is something we try to teach all of our patients, and we'll often use their fist or their hand as a teaching tool to estimate how much of a portion they're having, and comparing a fist of, let's say, potato or rice to how much carbohydrate that amount contains. Using their hand, it's a tool they always have with them. As well as a technique called carb factors. We use this for our more engaged, obsessive compulsive patients, where you can actually weigh your food and convert it to precise grams of carbohydrate. It is a useful tool for being able to learn portions, because if you estimate a food and then weigh it and see how much it actually contains, you can kind of train your eye to do a better job of estimating. So now getting back to the timing issue, not all carbohydrates digest at the same rate. Some are faster than others. This notion of the glycemic index was developed in Australia decades ago. And what they did is they had people consume different types of foods, and just to see how long it takes for the blood sugar to climb. And they were measuring the percentage of carbohydrate that entered the bloodstream as glucose in 2 hours' time. So for example, if you take a common food like pasta, pasta is a relatively low glycemic index food, which sounds funny because we know it has lots of carbohydrate, but the carbohydrates take their time. They don't digest instantly. So in the first 2 hours, only about a third of pasta's carbs have already digested and are in the bloodstream. The rest will digest after that. And I mean, I'm not big on memorizing long lists of glycemic index values. I just sort of group things. And I know pasta and legumes and veggies and chocolate. There's a good one. Chocolate is actually a low glycemic index food because it has a lot of fat content. It takes a long time to digest. The carbs will kick in eventually, but it doesn't tend to do it right away. The rapidly digesting stuff is important to know. Snack foods, potatoes, rice, cereal, sugary candies, these types of foods digest very quickly, raise the blood sugar fast. So again, the timing does matter. If you're consuming a rapidly digesting food, you're going to need to bolus in advance. With slower digesting foods, and this happens with very large portions, with low glycemic foods, with foods that take a long time to consume. It will also occur in patients with gastroparesis, and in some cases, those who are using a GLP-1 receptor agonist. We have to concern ourselves with the amount of time it's going to take for that food to digest. So if you have insulin, rapid insulin that's peaking in 60 to 90 minutes, and food that's taking 3, 4, 5 hours to digest, we have an issue. We're going to experience hypoglycemia after the meal, and then hyperglycemia several hours later. All right, so we have a number of options for dealing with this. One of them is using what's called a square or extended bolus when using an insulin pump. Another is a dual or combination bolus, which I tend to prefer. This is where some of the bolus is given up front, the rest is extended over time. But I think regular insulin for those on injection is also a good option with slower digesting meals, or just teaching patients to delay their injection depending on the nature of what they're eating. A few other things to consider in terms of food. Dietary fat will slow down the rate of gastric emptying, delays the rise in glucose. Large amounts of fat can also cause temporary insulin resistance. And when that occurs, the liver secretes more glucose than normal. So that can cause a secondary rise. So somebody who has a high fat meal is going to see a slow rise from the carbs and then another rise after that because of the insulin resistance that's set in. So for pump users, a basal increase works nicely. For those who are on injections, taking a small dose of NPH insulin after a high-fat meal can do a pretty nice job of offsetting the effects of the dietary fat. I'll often have patients take about 10% of their total daily dose as NPH to deal with short-term insulin resistance. What about protein? Can't ignore this. Protein generally doesn't affect glucose levels unless two special conditions are present. One is if somebody's eating very little carbohydrate, and that's become more popular these days with the low carb and the ketogenic diets. If somebody's not eating carbohydrate, some of the protein in their food is going to convert to glucose, upwards of 50%. So they have to start counting protein and dosing for that. So I'm not a big advocate of super low carb diets. I generally teach moderate carb intake with the right kind of choices. Choosing the low glycemic index carbs are just generally healthier foods. The other time protein can raise glucose is if you eat an enormous amount of it. And we're talking like you'd have to eat an entire chicken to accomplish this. More than 60 grams of protein at one time can cause an additive effect on the carbohydrates. So you have to add another 20 or 25 grams to your carb count when eating that amount of protein. Now, looking at exercise, I'm not going to talk a whole lot about this because Sherry covered some of this. Physical activity will actually improve insulin sensitivity. Think of insulin as a key. We have insulin receptors on our cells. Think of those as the doors. As in people who are very inactive, or even people who exercise and haven't been active for a day or two, they tend to become a bit insulin resistant because the muscle cells downregulate the insulin receptors. So what happens is that the glucose tends to remain in the bloodstream instead of getting into the cell. During physical activity, insulin receptors proliferate. So we have more doors for those keys to open. There's also a special door you'll see at the bottom right called GLUT4. And this is a special enzyme that shuttles glucose into cells in an insulin-independent manner. So you can take up glucose even without insulin present during exercise. That goes away as soon as the workout is over, and the receptors start to downregulate after the workout's over. But this enhanced insulin sensitivity can sometimes go on for 24 hours, especially after a really intense, prolonged workout. So I think Sherry mentioned it's necessary to make adjustments. People who exercise after a meal need to be advised to reduce their bolus insulin. Those who exercise before or between meals, when there's just basal insulin present, are typically going to need to consume some rapid-acting carbohydrate before they exercise. With long-duration endurance-type activities, and you were talking before about different tribes, different nationalities, and there are people who really, with type 1 and type 2, engage in endurance activities. We have to be ready for this sort of thing. And it's not just exercise, this also applies to house cleaning. I was working in the yard all afternoon yesterday, so it applied to me. In cases like this, not only do we have to either cut the bolus or consume extra carb, we also have to consider reductions in basal insulin. We also have to consider snacking at regular intervals. And with this, we have to pay careful attention to the risk of delayed onset hypoglycemia. the amount of the bolus reduction, if somebody is going to do so for exercise after a meal, it's a bit of a crapshoot. I'll often start out by recommending a 50% reduction, and then we fine tune from there. But with competitive and anaerobic activities, we sometimes have to increase the dose a small amount. I'll show you in a moment, these can often cause a slight increase in glucose levels. And with very low activity, people don't often think of this, but if you're not going to move as much as usual, you will need a little bit more insulin. So your bolus dose may need to be increased for very low levels of activity. With basal adjustments for pump users, we usually start out with a 50% reduction that needs to be made an hour prior to the activity. If you wait until the activity starts, it's too late. Basal insulin adjustments take an hour or two to start having a noticeable effect on glucose levels. And that's why the automated insulin delivery systems, or the hybrid closed loop systems that are out now, are not very effective for managing glucose during short-term exercise. With long-term activity and after the activity, they can be very helpful. But for typical 30 to 60-minute workouts, they don't work so well. So people still have to be taught to either reduce their bolus beforehand or consume rapid carbohydrate beforehand. For those on injections, and if they know they're going to have a very active day the next day, or if they take their dose in the morning, cutting the dose by 20 or 25% is a reasonable thing to do. For those using carbohydrate, again, this is a bit of a crapshoot. This is just kind of a general guide about how much carbohydrate to consume. The bigger you are and the more intense the workout, the more carbohydrates you're going to need. And I typically recommend snacking in half-hour intervals with long workouts. So you would cut these in half and administer them every 30 minutes. Remember, rapidly digesting carbs necessary. You don't want food that's going to sit in the stomach for a long time. And I mentioned delayed onset hypoglycemia, and this tends to follow, it can follow any form of exercise, but it's more common with exhaustive workouts where we deplete glycogen stores and we make the body much more sensitive to insulin. And there's several ways to prevent these delayed drops. Certainly, it helps to understand your body and when the delayed drop is expected. But cutting basal insulin modestly after the workout is a good start. Cutting back on the bolus doses that are given after the activity can also be useful. Or having free snacks. One snack that's become very popular for preventing delayed lows is chocolate milk. It seems to have a nice combination of a little carb, a little protein, a little fat. It's nice and slow burning and seems to do a pretty good job for preventing those lows. And everyone wants to know now, can exercise make blood sugars go up? I mean, technically, no. I mean, exercise and muscle activity are always going to burn some glucose, but some forms of physical activity will also cause the production of an excessive amount of adrenaline. Remember, those counter-regulatory hormones in this balancing act are working against the drop that the exercise causes. And if you're producing more adrenaline than you're burning of glucose, the net result can be a rise in the blood sugar. So the types of activities, we see this often with heavy weightlifting, sports that involve bursts of activity. I would probably include cricket in that mix. Any sprinting, performances that are being scored or judged. And when the competition level gets very high, just the competitive juices start flowing and blood sugars will have a tendency to go up. So there's a number of ways to prevent the rise, because a rise in glucose is not healthy. It's going to compromise performance. Many people will learn how to relax. Stress management techniques are very helpful for managing glucose with competitive sports. But for those who just can't seem to avoid this blood sugar rise, it's reasonable to give a little bit of rapid-acting insulin about a half an hour before these types of activities. We would give conservative doses, usually half the usual amount to offset the rise. So if somebody's glucose rises, say 200 points when they play a competitive sport, we'd give enough insulin to prevent a 100-point rise and then monitor closely. Ideally, using a continuous glucose monitor so that you can track the results and also be notified early if the glucose begins to drop. Another part of thinking like a pancreas is involving the other hormone that the beta cells produce, which is amylin. People with type 1 are completely lacking in the amylin hormone. Those with type 2 produce insufficient amounts. And we have a replacement for the amylin hormone called pramlintide, brand name Simlin. It's an injectable hormone. And what it does, this hormone suppresses glucagon production. It induces satiety, so people tend to eat less. But the big thing it does is it slows gastric emptying. So the combination, all three of these are involved in reducing the amount of glucose entering the bloodstream. So if you think of the big picture of how glucose is regulated, insulin's job is to take the glucose that got into the bloodstream and get it out. Simlin's job is to control the rate of appearance of glucose in the bloodstream. So the two sort of work together. And you can survive without the amylin hormone, but it really complicates things. And this is why glucose spikes so much in patients with diabetes right after meals. It's why we tend to overeat, and weight gain is so common, and following a diet is so challenging. It's the lack of this hormone. But when the two are working together, it can really improve things. But considering it is a complicated hormone to use, it may be more complicated than an insulin. Getting the amylin dose right, adjusting the insulin dose and timing to match it, it's not easy to do. Plus, you have to consider the side effects that use of a medication like Simlin can induce. Nausea and difficulty treating hypoglycemia is also common because it slows down the digestion then as well. That's why it's not used more. But in patients with type 1 and type 2, it's possible to prescribe off-label things like GLP-1 receptor agonists and metformin and SGLT2 inhibitors, just to supplement the insulin when needed. All right, so those were the major factors, and I try to list out some of the others. I don't know that we have time to go through every one of these, but you can see how many things can affect glucose levels. It's an enormous number of variables, and I probably have not exhausted the list. There are medications we didn't get into that can affect glucose levels, but a lot of things affect it. Safe to say, it's not a simple matter of just adjust the insulin, match it to your food, and everything is perfect. You can do all the right things and still have glucose levels that are out of control. So it's important to set realistic goals with patients. Talk to them about the percentage of readings, or if you're using a CGM, the percentage of time they spend in range. This is a metric that's gaining greater importance. And that's something that I always emphasize, and also talk about what's acceptable in terms of hypoglycemia, how often it's allowable. We're not going to eliminate all cases of hypoglycemia in patients on insulin, but we can keep it to a safe, reasonable level so that it's not really having a significant effect on a person's quality of life. So again, this is the basis, this balancing act. This is what's involved in thinking like the pancreas. That was my whirlwind tour of insulin management. My email is here. I encourage anyone who's interested in discussing this further and learning more, reach out to me, and I'll be happy.